I would like to show you today's lecture about orofacial pain, common diagnosis and management. How can we diagnostic trigeminal neuralgia? First of all, examination. In case of light touch of trigger zone, can be attack of neuralgia. Electrophysiological testing of trigeminal reflexes by special devices. A local anesthetic block. If you will use local anesthetic block, it will temporarily eliminate trigger zones. And we can use MRI of brain plus MR angiography. And now about management of trigeminal neuralgia. At first, pharmacological treatment like carbamazepine, oxocarbazepine, etc. Surgical options. We can use microvascular decompression, trigeminal ganglion rhizotomy, or gamma knife surgery. And new alternatives. It is transcranial magnetic stimulation, TMS, transcranial magnetic stimulation. But the pain can be recurrent to all these options. And we can only try to treat trigeminal neuralgia, but it doesn't mean that our treatment will be successful. Now let's talk about other facial neuralgias. Glossopharyngeal neuralgia. Nervus glossopharyngeus. It is ninth pair of cranial nerves. This nerve innervated pharynx, posterior part of tongue, ear, infraauricular and retromandibular areas. Nervus facialis innervates ear, anterior part of tongue and soft palate. And we need to remember that facial paralysis indicates motor route involvement and may result from Ramsay-Hunt syndrome. About Ramsay-Hunt syndrome I will tell you later. And occipital neuralgia. Greater or lesser occipital nerve is the same upper cervical spinal nerves. So big group of facial neuralgias is post-herpetic neuralgia. You know that herpes is caused by herpes zoster. Herpes zoster is a recurrent infection that follows primary virus zoster chicken pox. And you know that virus zoster is a neurotropic virus. Herpetic neuralgia, it is pain along the nerve plus vesicles on skin. Pain may be present before the vesicles erupt. But sometimes we can see zoster sign herpetic neuralgia without vesicles. 15-20 of herpes zoster cases involve the trigeminal nerve, facial or oral pain, which will resolve in a month time. You can see intraoral signs of herpes zoster. Postherpetic neuralgia is a persistent neuralgia that continues for more than 3-6 months after acute herpes zoster eruption has healed. Risk factors for herpes zoster. More than 65% of patients elder 70 years. Females more often than male. And 25% of herpes zoster get postherpetic neuralgia for more than 1 year. And now I would like to shortly talk you about pathophysiology of postherpetic neuralgia. It is combination of peripheral and central nerve injury. Virus zoster injures peripheral nerves by demyelination, Wallerian degeneration and sclerosis. And this virus can cause cranial nervous system changes, atrophy of dorsal horn cells in spinal cord, and can cause Ramsay-Hunt syndrome. It will show by rash and facial paralysis. And it leads to persistent chronic burning pain, paresthesia, hyperalgesia, allodynia, plus sensory deficit for months to years after zoster lesions heal. What about treatment? Prevention and treatment. I'm sorry. Prevention: leave attenuated virus zoster vaccine for patients elder than 60 years old. And treatment: patients with herpes zoster, antivirals given early in the course of disease, acyclovir, systemic corticosteroids started within 10 days and continues for 3 weeks, like prednisone, subcutaneous infiltration, triamcinolone, acetonide, plus local anesthetics in areas of eruption. And steroids, you need to know that steroids help maintain the level of sensory perception and normal excitation of neurons. They also decrease neuronal inflammation and chronic pain. And topical treatment. Anesthetics. It can be lignocaine patches or eutectic mixture of local anesthesia. Analgesic, capsaicin, selective safe fiber and neurotoxin, depletes substance P. Drugs like amitriptyline, nortriptyline, doxepin, dizipramine, fluoxetine. These drugs have antidepressant, cranial nerve system effects and sedative effects. Or gabapentin, pregabalin and carbamazepine, phenytoin. In some cases, we can propose for that patients surgical management, surgical treatment, like nerve block, surgery and peripheral nerve or dorsal root. Next big group of orofacial pains is neurovascular pains or migraine. It is trigeminal autonomic cephalgias and divides into cluster headache, hemicrania, and short-lasting unilateral neurology-form attacks. Let's talk about migraine. The prevalence of migraine is around 13.2% in the general. More women than men, 3-to-1 ratio. And migraine can be subdivided into migraine with aura, neurologic focal symptoms producing visual and sensory alterations preceding the attack, and migraine without aura. Location of migraine. As usual, at the area of first branch of nervus trigeminus, but less commonly in second and third trigeminal nerve branches, and as usual it is unilateral pain. Onset is so variable. Quality of pain, like throbbing, pulsatile. Intensity, from moderate to high. Frequency of pain, once per day. But, so big duration, from 4 hours to 72 hours. Till 3 days. Aggravating factors: alcohol, wine, cheese, poor sleep, exercise, and very often bright lights. And how can we alleviate it? Simple advice: avoidance of triggers and analgesics, and go to a dark room. And other associated symptoms with migraine: autonomic symptoms, possible aura. How can we treat migraine? At first, abortive meditations, Tylenol, ibuprofen, triptans, dihydroergotamine. Preventive medications, beta blockers, verapam, topiramate, Botox. Avoidance of triggers and change of lifestyle. Avoidance of triggers. No alcohol. It's terrible. Change of lifestyle. Very popular advice. Don't worry, be happy. And completely end alternative medicine. And next big group of idiopathic pain. Next big group of orofacial pain, idiopathic pain. It is burning mouth syndrome and persistent idiopathic dental pain, aka atypical odontology or phantom tooth pain. What about burning mouth syndrome? It is oral pain or discomfort affecting the tongue, lips, mucous membrane in the presence of normal tissues. Most found in more than 60 years old patients, 5 times more in women than in men, especially post-menopause. Primary or secondary burning mouth syndrome can be as a result of diabetes, nutritional deficiencies, or alterations in the cellular flow. And this syndrome also related to candida infection, oral lichen planus, hyposalivation, medication anemia, or Sjogren's syndrome, etc. And about management of burning mouth syndrome. In the first place, saliva replacement and stimulating products. Then, oral rinses or lidocaine. Clonazepam or clonopin. Certain antidepressants. Cognitive behavioral therapy to develop strategies to address anxiety and depression and cope with chronic pain. And lifestyle changes. Avoid spicy food, alcohol, tobacco, acidic foods and liquids, coffee, cinnamon, mint, etc. And next big group of dental pain, persistent idiopathic dental pain. It is persistent pain perceived in teeth or adjacent dental alveolar tissues, occurring without any identifiable cause. This can be in close relationship to a causal event, such as a dental procedure, but not necessarily. Prevalence of it: 0.6 to 1.2% of people receiving a root canal treatment. Range of pain variable, but usually low. and about management of persistent idiopathic dental velar pain. At first, education of patients how to deal with this pain. Topical analgesic or anesthetizing cream. Tricyclic antidepressants like gabapentinoids. And some researchers showed that Botox using is helpful for treatment persistent idiopathic dental velar pain. Another group, painful post-traumatic neuropathy or PPTN. Etiology. More often it is injuries to the trigeminal nerve like third molar impaction removal, transient anesthesia or paresthesia of lingual or inferior alveolar nerve seen in 0.3 to 1% cases. Implant placement 1 to 8%. Removal of cyst, tumor or jaw. Odontogenic surgery. For example, genioplasty, osteotomy, 5 to 30%. And what is not so is very unpleasant for us, like for dentists, post-root canal or endodontic surgery chronic pain. It can seen in 3 to 13% cases. Because of root canal treatment is very widespread dental treatment, but to 13% cases can develop post-traumatic neuropathy, painful post-traumatic neuropathy. And of course, a reason of this kind of trauma, of painful situation can be facial trauma. At first, let's give definition. What does it mean, pain? According to Cambridge Dictionary, pain, it is a feeling of physical suffering caused by injury or illness. And other sources give us another definition of pain. According to Endodontics 4th edition, orofacial pain, or OFP abbreviation, is defined as pain whose origin is below the orbital line, above the neck and anterior to the ears, including pain within the mouth. They are shown about localization. American Academy of Orofacial Pain gives us definition of orofacial pain, that it is the specialty of dentistry that encompasses the diagnosis, management and treatment of pain disorders of the jaw, mouth, face, and associated regions. The specialty of orofacial pain is dedicated to the evidence-based understanding of the underlying pathophysiology, etiology, prevention, and treatment of these disorders, and improving access to interdisciplinary patient care. These disorders, as they relate to orofacial pain, include but are not limited of temporomandibular muscle and joint (TMJ) disorders, jaw movement disorders, neuropathy. But according International Headache Society, orofacial pain defines like pain below the orbitomedial line anterior to the pinnae and above the neck. Another international organization, International Association for the Study of Pain, gives us definition that pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And word pain is from Latin word poena, means punishment. And now let's talk about terminologies. To describe pain, we use different terms. First one, algogenic. This notion means causing pain. Allodynia, pain that occurs without noxious stimulation at the site of pain. Analgesia, it means absence of pain. Instead of anesthesia, it is absence of all sensation. Please, doctors, remember that analgesics and anesthetics, it is different groups of drugs. Dysesthesia, unpleasant, abnormal sensation. Hyperalgesia, increased sensitivity to stimulation evoked pain. Hyperesthesia, increased sensitivity to stimulation. Hypoesthesia, diminished sensitivity to stimulation. Inflammatory pain, it is pain that emanates from tissue that is inflamed. Neuropathic pain, pain that is generated within the nervous system due to some abnormality of neural structures. Nociception, the mechanism that provides for the reception and conversion of potentially noxious stimuli into neural impulses and the transmission of such impulses to the cranial nervous system. Noxious stimulus, a tissue damaging stimulus. Paresthesia, an abnormal sensation, whether spontaneous or evoked. Visceral pain, deep somatic pain that originates in visceral structures. about orofacial pain classification. Orofacial pain classification. Different orofacial pain classification based on location and in mechanisms. An international classification, ICOP-1, International Classification of Pain, developed recently considering different pain experts groups and disciplines. What about characteristics of pain? According threshold and intensity. If the intensity of the stimulus is below the threshold, pain is not felt. But as the intensity increases, more and more pains is felt more and more. Next characteristic of pain, adaptation. Pain receptors show no adaptation, and so the pain continues as long as the receptors continue to be stimulated. Localization of pain. Pain is poorly localized, but superficial pain is better localized than deep pain. And visceral pain is often referred. Next characteristics of pain. Emotional accompaniment. Pain sensations are commonly accompanied by emotions. And I hope you know it yourself. Influence of the rate of damage of the intensity of pain. If the rate of tissue injury is high, the intensity of pain is also high, and vice versa. What types of pain we know? First type, based on duration. It can be acute or chronic pain, based on duration. A popular alternative definition of chronic pain involving no arbitrarily fixed duration is pain that extends beyond the extended period of healing. Type based on cause. Somatic pain, neuropathic pain, and psychogenic pain. Depending on the quality, pain can be a sharp, prick, well localized, or dull or edging, throbbing, and poorly localized. Type of pain depending on the pattern. Pain can be intermittent or continuous, depending upon the location. Pain can be localized, diffuse, or referred. But now let's talk about types of orofacial pain. Not pain at all, but orofacial pain. Orofacial pain can be odontogenic relative to with dental structures, muscles, bones, temporomandibular joint called musculoskeletal pain, connected with nerves, neuropathic pain, and blood vessels, neurovascular pain. And of course, idiopathic or unknown type of orofacial pain. Orofacial pain attributed to disorders of dentoalveolar and anatomically related structures. Usually inflammatory in nature and affect dental structures, pulpal, periodontal or gingival pains. Other non-dental structures, pain affecting mucosal, osseous or glandular tissues. And doctors, I would like you to remember that dentists are highly skillful in identifying and treating those eliminating cause of inflammation or infection. And now I would like to tell you about the classification, more precise classification of orofacial pain. It divides into two axes, axis 1 and axis 2. Axis 1, somatic pain. Chapter A, superficial somatic pain. It can be cutaneous pain or mucogingival pain. Division B, deep somatic pain. As I told earlier, it is musculoskeletal pain, muscle pain, myofascial facial pain, myositis, temporomandibular joint pain, osseous and periostal pain, soft connective tissues pain, periodontal dental pain, or visceral pain, pulpal pain, vascular pain, neurovascular pain, visceral mucosal pain. Second big division of first axis, neuropathic pain. Division A, episodic neuropathic pain, like paroxysmal neuralgia, trigeminal neuralgia and the glossopharyngeal neuralgia, and neurovascular pain. And group B, continuous neuropathic pain. It can be neuritis, herpes zoster, post-herpetic neuralgia, differentiation pain, atypical odontalgia, and sympathically maintained pain. And access to psychological conditions. It can be mood disorders, anxiety disorders, somatoform disorders, and other conditions such as stress-related psychological response. And now let's talk more detail about every this type of orofacial. Once again, orofacial pain has two axes. Axis 1, physical pain, and axis 2, psychological conditions. So, axis 1, physical pain. First big group, somatic pain, superficial somatic pain. It can be cutaneous pain, mucogingival pain, and group B, deep somatic pain, like musculoskeletal pain, muscle pain, myofascial pain, myositis, temporomandibular joint pain, osseous and periostal pain, soft connective tissue pain, periodontal dental pain, and second group, visceral pain, like pulpal pain, vascular pain, neurovascular pain, and visceral mucosal pain. And second group of first axis, physical pain, called neuropathic pain. Episodic neuropathic pain, paroxysmal neuralgia. The most common is trigeminal neuralgia. More rare, there is glossopharyngeal neuralgia and neurovascular pain. And group B, continuous neuropathic pains. The neuritis, herpes zoster, postherpetic neuralgia, deafferentation pain, atypical odontalgia, sympathically maintained, and axis 2, psychological conditions. First big group, it is mood disorders. What is it? It is a situation when general emotional state or mood is distorted or inconsistent with your circumstances and interferes with your ability to function. Next big group, anxiety disorders. You know that anxiety disorders are a cluster of mental disorders characterized by significant and uncontrollable feelings of anxiety and fear, such that a person's social, occupational, and personal function are significantly impaired. Anxiety may cause physical and cognitive symptoms such as restlessness, irritability, easy fatigability, difficulty concentrating, increases heart rate, chest pain, abdominal pain, and a variety of other symptoms that may vary based on the individual. Third big group, somatoform disorders. Somatoform disorders are a set of physiological conditions where a person experiences bodily symptoms that can be accounted for by a medical or neurological diagnosis. But how can we pain intensity measure? There are different ways to measure pain intensity. First one, the most easy, it is visual analog scale. With this scale, patients themselves choose grade of pain, how patient feels it herself. There are shown different types of VAC, visual analog scale. I have this one. What principles of using that scales of this scale? Patient herself put this line according to different smiles, but in the opposite side, doctor has possibility to measure it in absolutely numbers from 0 to 100. Next way to measure pain intensity, it is McGrill Pain Questionnaire. This questionnaire includes 78 adjectives to describe the pain. But more, they're shown schematically human's body, and patient can to put marks in different areas where patient feels pain. But they develop different other numerical scales. For example, multi-axial assessment of pain, abbreviation MAP, by Turk and Rudy. It is a 61-item questionnaire. The assessment included a 61-item questionnaire, the West Haven Yale multi-dimensional pain inventory. This abbreviation WHY-MPI, which measures adjustment to pain from a cognitive behavioral perspective. But as can we see, it is so difficult ways to measure pain intensity for dentists. And what about disease history? What we need to ask our patients? At first, of course, chief complaint. It must be, firstly, localization of pain. Then, onset. When and why pain begins. And we need to ask about characteristics of pain, quality of pain, behavior, and intensity of pain, concomitant symptoms. aggravating and relieving factors. Aggravating and relieving factors. What factors can stop this pain? Past consultations or treatments. It's called medical history. And of course, past medical history and review of systems. And psychologic assessment. What about physical examination? In which way we need examine our patients with orofacial pain? At first, inspection. Hand and neck, skin, swelling, regional anatomy, and orofacial asymmetry. They are shown Russia boxer after meeting with Ukrainian boxer Klitschko. We need use palpation of masticatory muscles, and we need conduct tests for strength and provocation. Of course, we need measure assessment of range of mandibular movements. We can use standard rulers or a special device, a special scale to measure a range of mandibular opening. Palpation of soft tissues and lymphatic groups of lymphatic nodules. Of course, palpation of temporomandibular joint. And palpation of muscles of the neck. Next step, cranial nerve examination. They are shown Valais points palpation. General inspection of ears, nose, oropharynx. Examination and palpation of intraoral soft tissues. Examination of teeth, periodontium, and occlusion. I would like to show you this table. They are shown differential diagnosis for different orofacial pain disorders. Intracranial pain disorders we need differentiate with neoplasm, aneurysm, abscess, hemorrhage, hematoma, and edema. Primary headache disorders must be differentiated between migraine variants, cluster headache, paroxysmal hemicrania, and cranial arteritis. Different types of neurovascular disorders. We need differentiated between keratodynia and tangent type headache. But as can you see, the biggest group is neurogenic pain disorders. We need to differentiate between paroxysmal neuralgias, trigeminal glossopharyngeal, nervus intermedius, superior laryngeal nerve, continuous pain disorders, deafferentation, neuritis, postherpetic neuralgia, and sympathically maintained pain. In case of present intraoral pain disorders, we need to differentiate between dental pulp, pulpitis, periodontium, mucogingival tissues, tongue, and burning mouth syndrome. If patient has temporomandibular disorders, we need to differentiate between masticatory muscles, temporomandibular joint disorders, and associated structures. But associated structures can show us pain from ears, eyes, nose, paranasal sinuses, throat, lymph nodes, salivary glands, neck. So, doctors, at the end of this lecture, I would like to recommend you a few sources according to this topic, according to orofacial pain. First one, it is Clinician's Guide, Orofacial Pain, by edition of 3 editors. Jeffrey Oakison book, Bell's Oral and Facial Pain. You know Jeffrey Oakison, it is a very famous American scientist in the orofacial pain field and temporomandibular disorders field. And guidelines called Orofacial Pain, edited by René de Leo and Gary Glasser. Thank you for your kind attention.